My name is Ira Kirschenbaum. I am the editor of the Journal of Orthopedic Experience and Innovation. Tonight, we have a topic that straddles experience, experience, and innovation. We have three amazing panel members. I'll have them introduce themselves. First, Frank Buttacavoli. How you doing, Frank? Could you
Great.
introduce yourself? Tell us where you're from and whatever you want to say.
Sure. Thanks for having me. I'm at University of Texas Health in San Antonio. I'm hip and knee surgeon here, work with a lot of residents, and but I grew up in Miami Beach, Florida.
Very good. Very good. Very good. And Adam Freedhand, how are you doing?
I'm doing great. Thanks for having me. It's a pleasure to be here. First one, so I'm pretty excited about it. I'm a orthopedic surgeon at the University of Texas in Houston. But as you kind of found out on the back end, I'm actually originally a New Yorker, and we grew up in the same town essentially. So it's a pleasure to be here. This is a great topic. I'm looking forward to talking about this. This topic has evolved and means actually less to me now than it used to, and we'll get into that later. But thanks for having me.
Excellent. And we have from Florida, Ed Stolarski.
Hi, I'm Ed Stolarski. I'm in Sarasota, Florida, private practice, big referral center for revision knees. So this is a great topic.
Excellent. So first, I'd like to start, tonight we're going to be talking about the topic is metal sensitivity in knee replacement, whether it's a real concern or much ado about nothing. All right. So first, I'm going to sort of go around the panels and ask them. I want you to think about a few years back, maybe 5, 10 years back in your practice. 10 years, let's go back. How much was metal sensitivity on your mind? Is this a biologic science thing, a patient perception? Well, 10 years ago, what was it? Ed, let's start with you.
Well, metal sensitivity 10 years ago, I was revising a lot of metal and metal hips. So everybody was aware of sensitivity to cobalt and chromium.
Yeah.
In the knee world, I think that there's companies that have been proponents of metal allergies and their problems since they had the technology being utilized for their implants. But I think it was on the radar, but it was not as focused on as it is now. So I'm sure 10 years ago, I was not looking so critically at revision total knees for metal allergens.
Yep. And Adam, what's your feeling about, the experience back when you were earlier in your career versus now when you're still early, but not as early?
Yeah, I mean, I think I would agree with what Ed said regarding metal on metal, metal ion issues. But as it pertains to knees, I mean, this was always a concern at some level. And again, I think to put it into perspective, when I was in private practice briefly in New York after fellowship, and then in Philadelphia after that with the medical legal environment, you're much more your awareness is much more heightened to little things like this that can be problematic. You know, there's kind of two ends of the spectrum here, and I'm sure we'll get into this a little bit. There's the people that think that it's really super prevalent, and there's people that believe that it's almost completely non-existent. And I think the reality is someplace in the middle. With regards to knee replacement surgery, when we think about metal sensitivities, I mean, I think we all know that not all of our patients do great after surgery. And so when they don't do well, and to coin a Bob Booth, we were talking about Bob Booth earlier, x-rays that look great but feel bad, we start to wonder, what is it? The components look good, the patient healed fine, they're not infected, they don't seem unstable, what is it? And so I think, a lot of us had a heavy level of concern when we faced those patients 10, 15 years ago. I would argue less so now because of the technologies and the metallurgy that we have available to us now. So
Sure.
things have changed a little bit over time, Ira.
hmm Frank, some comments on this?
Yeah, not to duplicate, I've been in practice for 12 years. So I think early on in my practice, it saw me more than I saw it. I think now, 12 years later, I think about it more. On my intake form, the question's still the same. I ask people, do you have a known sensitivity to metal? Do you have issues with jewelry? That's still my main question that I ask people. But for me, when I started my practice, looking at that perfect x-ray, for me, it was a diagnosis of exclusion. It was the last thing I was thinking about.
Right.
And kind of the harder patients for me were the ones that came with data that said they had an allergy, and I really couldn't find anything wrong with their implant. I didn't think they were unstable. I didn't think they were infected. I didn't think they were loose. And some people, those were some of my early revisions that came to me with data that said they had the problem. And but I had interesting patients with that too. I had patients that I think it was maybe a combination. I think maybe they did have subtle midflexion instability because they had a knee on the other side, and I took an x-ray of that knee, and that knee was nothing special, and they had no problems with that knee.
Right.
So I don't know if there's some host variation with the response, but I definitely don't understand it perfectly now, but I think I have gained a little bit of knowledge with experience over the last 12 years.
So a couple of questions. What are we talking about clinically? What would be a quintessential, I'm pretty sure this patient has a metal allergy. Okay, I'll start with Adam this time. And
Yeah,
yeah,
I think that's a great question, Ira. I mean, I think the classic person is almost always a woman, and they very commonly will report difficulty with costume jewelry and things like that. Um, we do ask that question of our patients in our questionnaires, but very commonly we see them as revisions. And to Frank's point, they are diagnoses of exclusion. They come to you and you're kind of wringing your hands. Okay, what do I do next? I have this patient that said they have costume jewelry difficulties. They have a cobalt chromium femoral component in. They've got recurrent infusions, a swollen stiff knee. They don't necessarily have, a true metal hypersensitivity skin reaction, but you're suspicious. What do you do next? You know what I mean? So
yep.
this question is one that I think has probably haunted us at one point or another in our careers, because we know that our ability to test for this in a very accurate way is somewhat limited.
Mhm.
I do test for it. I test for it a lot less than I used to. But when you order a test, you should want to see what the result is. And when the tests that you're ordering are not that reliable, it's a little bit of an uncomfortable situation for the clinical practitioner.
Ed, what are your thoughts about that? And also, how often do you really feel you see this in your practice?
Well, on the clinical side, I think it's a continuum. It's someone that I think I have a very high suspicious index of suspicion. They're female. They're stiff. There's no other reason for this significant arthrofibrosis, and the knee's always painful globally.
Yeah.
And the exam's negative, the inspection workup's negative, all of it. So that's and they do seem to get better. I tell them this on the clinical side for that particular knee. I tell them it's not very likely they're going to be normal. If I'm clinically, they have their arthrofibrosis, they're 10 to 85 swollen. I don't see a lot of effusions. A lot of times it's just like dense scar tissue. And excluding everything else, when I revise them, I tell them to expect it's like cold taffy instead of warm taffy. The knee is always going to be a little stiffer, and that the biology with the knee and then their soft tissues have changed. And that I don't think it's a miracle when you take out the nickel implants. I think they're improved. They have better range of motion, but they're not the same as someone who had a normal course of postoperative events. So I think it's an exclusion diagnosis. And even if they have other issues, mid-flexion instability, whatever it is, malrotation, I would still take that variable out of the equation when we have the knowledge that they have a nickel allergy. I do not test every revision for a nickel allergy.
Right.
Maybe I should. I don't know.
I don't know. Frank, you screen people, right? Beforehand.
I don't anymore. I treat everyone as if they have a nickel allergy
Okay.
now. That's been a big change in my practice in the last year because the implant I was using came up with options that made me comfortable. But to kind of add on to what they're saying, I think of one very specific patient that I didn't inherit. I did the initial surgery. And even with my intake form, just to tell a story, I do her knee. I love her knee. I love her x-rays. And she hates it.
Right.
And,
Yeah.
I aspirate her and do all this stuff and everything's negative. And then, like, after 3 or 4 more visits, she finally tells me, she's like, when I got an IUD, I had a really bad reaction and I had to have it removed.
Mm,
And then I got the testing and then I took it out and I put one of my first solution revision personas, and she did great. And she did have some skin changes. She had some of the other classic things that come with these allergies. Um, but, poor history taking on my part. I wish I would have caught that before, but I obviously wish you would have told me. I'm like, hey, if you've had a problem like that severe with, and maybe she didn't know that an IUD had metal in it or wasn't educated on it after. But when she told me that story, that really hit. So that's my most classic patient.
yeah, it is. Yeah. That's a great
But
story.
they're definitely not always that straightforward.
Right.
And for me, the hard part is when they come to me with data that they say they have a sensitivity or an allergy. At that point, it becomes a medical legal concern for me. But now I don't have to worry about it with the implants that I'm using.
Yeah, let's talk about the medical legal part a little bit because taking a well, you can't fully take away medical legal concerns, but is the public driving some of the discussion on the internet, or public being aware of metal sensitivities, forcing people's hands to think, sort of forcing surgeons' hands to think more about this? What do you think, Ed?
Well, I do. I actually had a patient that came to me with a positive test, a painful knee, and she said, I spoke to a lawyer. And she did. She spoke with a lawyer and brought up the fact that this doctor did not test her, nor did he ask her if she had any allergies. I revised the knee. I told her there was no way I could tell her definitively if her problem was coming from her nickel sensitivity, but it's certainly on people's radar. And the lawyers just need a hook. They just need a hook. You're writing a check.
We have a line in the Bronx that the presence of a bad result means a lawsuit.
Yeah.
So that could be it. Adam, medical legal concerns, ever push your hand to in
Yeah,
this
I mean, I'm the son of a lawyer, and my dad did a lot of medical malpractice back in the day, so I certainly had a high awareness around it. I do think that ultimately at the end of the day, if the patient really believes it's a problem, it's a problem because you can
right?
do a perfect job, like have all seen X-rays that look great, and you don't understand why a patient's unhappy. It's obvious, like to Ed's point, if somebody has bad arthrofibrosis, they're going to be unhappy. But sometimes it's not always that clear cut. Sometimes they look good but feel bad, and medical legal concerns are always an issue in that regard. But the broader overarching issue really is that we just want to make our patients happy. So if we have a patient that's unhappy for whatever reason it may be, it kind of is something that doesn't sit well with us. And if their belief is it's because they have an implant that they're allergic to, that perhaps makes matters even worse if that maybe isn't the reason, but we're contemplating taking it out because they have this belief. So I think, and it depends on regionally where you practice and where you live. And my attitude towards medical legal issues has changed as I've gotten older and as I find myself in a different practice environment. But it's always there, and I think it's primarily driven by our desire to make patients well.
Yeah.
Well, let me talk a little bit more about painful total knees because you could look. I remember an article quite a number of years ago by Michael Mont, about looking at patients' perception of their knees. And we know that forgotten hip scores are are off the roof, in a positive way. And it's not the same in the knee. Um, you can have 60% of your patients think it's 70% think it's really excellent. 20% think it's very good, and 10%, want to run you over with their car, on alternate Tuesdays. So, given that already situation, how do you determine, let's take that 10% who are not happy. Okay, so what's your protocol with them? They come in, they're that 10%. You think you look at your X-ray at first, and you do you did the case. So this is not someone that was sent to you, Ed, on a revision. It was so you did the case. So Frank, here comes this patient. It's the same day you did 8 other joints. The other 7 people are doing well, and this one is not doing. So what's your sequence? What do you go through to start honing this down to a diagnosis of exclusion?
Sure, unless there's something grossly obvious on imaging, for me, everyone's infected until I prove otherwise.
Okay.
I
And what's
rule
your
out their infection.
So you do ESR, CRP.
Anybody that I'm seeing after 6 months, if
Hmm.
they come in and they complain of worsening symptoms, I'm going straight to an aspiration in
Okay.
those patients. Acutely, I don't like to do that. Acutely, I tell my total knee patients, you don't like me that much for the first 2 weeks. So if they come in at week 4 and they say, oh, it's still really hurting, I might get some labs to trend labs if I'm worried about it or just for completeness. But that's kind of a different patient, that acute. But 6 months and later, they're coming back and they're saying, I don't like this. I go straight to an aspiration.
Hmm. And let's take that same patient and add that patient the aspiration. The first aspiration is negative. Let's say, Ed, you did the same thing that Frank did. What's your next step? Let's bring this eventually to metal sensitivity.
First, I look at them like they're not my patient, right? So I take that in, because to be honest, when I look at everything and there's a positive nickel sensitivity, I'm like, at least it wasn't what I did. But a painful total knee, minor or not mine, I try and look at it the same, and it's hard because you get defensive. But I'll do a sed rate and CRP for a baseline just to see where they are. Aspiration, if I have a high clinical suspicion, or not even high, just moderate. A good exam. I hate bone scans, even 15 months, 2 years later. Suspicious for infection, loosening, or can be normal up to 5 years. Okay, but if I'm looking for, I'm going to revise this knee, and I'll use the bone scan to help me decide if it's loose or not. But anyway, I work them up. I also look at what their anxiety and depression score was.
Yeah, I was wondering about that.
Or I will tell you, those people come in with a high anxiety. They bring in a whole folder with them that discuss their primary total knee, and they got their little pad of paper and legal pad and 4,000 questions, and they're waiting for a shoe to drop just with the conversation. I take that in the back of my mind as a complete separate risk factor, independent risk factor for unhappiness after the total knee. So an objective exam, aspiration, usually if I'm even somewhat suspicious, um, X-rays, images. Like I revised the Scorpio knee today that overhung a good 3 centimeters on each side.
Wow.
She had it 19 years ago and she loved it. So I don't know what I'm looking for X-ray besides something gross like obvious ligamentous laxity or gross malposition. But it's so an infection workup, a true honest exam, and try and understand their history on why they're hurting, when they're hurting, what exacerbates it, what makes it better. I had a lady angry because after playing tennis every day and golfing, she had to ice her knee at night. I don't know what to tell you. I don't know what to tell you.
Yeah. If I played tennis and golf all day, I'd probably be icing
Yeah,
every
right.
part of my body. You know.
Yeah.
So
But
this-
that goes to setting expectation, right? So I spend more time discussing risk of surgery and management of what I think their expectations, what I think they are, and what they think they are, and they need to align. And often, you can have someone who you might clinically think their knee's mediocre, and they're happy because they're doing what they want to do, and they're appropriately enjoying what they have. And even if they need a revision, they're like, I'll just live like this. I feel good. Is it going to fall apart? No. Okay, I'm fine.
Interesting. I'm going to try something else I haven't tried on any other open mic is a poll, a quiz on metal sensitivity. Can you guys see this?
Yes.
Yep.
So somehow you're able to answer this. Is there some way people can answer this?
Yeah, you can click on it. Ira, it
Click
works.
on it. There you go. Okay. So why don't people try to start answering this in the audience? Metal questions are always in my workup. Um, if your current implant is a particular kinematic design, would you change to a different kinematic design if it was hypoallergenic? Um, I think that's an important question because if you're used to using, let's say, a kinematic alignment knee with a big medial sphere, and now the patient is known hypersensitivity or suspect it, you're now using a knee you're not used to as much. So, it's very interesting to see. Metal sensitivity, patient physiological reaction to certain metals is probably more prevalent than we think because the testing we use is limited. The concept being if we had an incredibly awesome test, like a cynosure for metal, would that be a game changer? You know, in that kind of way.
It's a great point. Like whatever I get from dermatologists on some of these patients, it's all over the place. And then, a lot of times if I ask for something, I can't even get it. It's quite expensive and insurance doesn't cover it often. So I think
Usually
that's
not, Frank. I'm glad you brought that up, Frank. Usually not. I mean, the problems with lymphocyte transformation testing and skin patch testing, which are the two most common ones we use, at least in Houston, they're upwards of $600 to $700 a pop. And if you're doing LTT, depending on how many things you want to test, it can get upwards of $1,000. So that's a lot of money for folks.
All right. So we have a question from Arjun Patel. Arjun, you want to undo your mic and ask your question, Arjun?
Yeah, so I was just curious. We talk about all these metal allergies, but if we're putting any foreign product inside a knee or a hip, how do we know it's not the cement? Or if you do a patch testing and someone shows they're allergic to cement, how do we know? How do you differentiate if the allergy is true metal allergy versus a cement allergy? But we talk about these metal allergies and we isolate the total knees, but our hips also have a little bit of titanium, a little bit of nickel in them too. So if every painful hip that comes, do they also get a workup, or does the thought process or the diagnosis cross your mind in regards to a metal allergy and a painful total hip, for example?
Let's start with the great questions, Arjun. Let's start with the idea of cement allergies. Someone wants to take that on.
Yeah, they exist. I mean, I've seen it, right? So when we test for these things, cement is one of the things in particular, monomer from methyl methacrylate, gets tested as both in the LTT test and in skin patch testing. So you can specifically test for those things if you like. I mean, I think Arjun brings up a great point. We don't work up the painful total hip in the same way we work up the painful total knee. We kind of compartmentalize those two things, and maybe we shouldn't. And then the other question really it becomes, what are the potential sources of these metals, right? I mean, we all see metal staining of tissues through cutting blocks when we're using saws and things like that. And, more skilled people perhaps have less metal debris that's shed by the saw. And we've seen studies where, all of these ion levels are elevated, even if people have knees that are hypoallergenic or coated. So there's a lot of things that make this topic difficult to completely understand in a very scientific way. And that's kind of why it's interesting to talk about this because everybody has a little bit of a different take on it.
Yep.
Yeah.
Frank or Ed?
You know, you asked what I thought about metal sensitivity 10 years ago. I'm 10 years behind in understanding cement allergy. But, you know, I have patients also come to me with a report that says they're allergic to the cement. And I have yet to do a press fit only revision. So they're to me, they're an even more difficult patient to deal with, because cement is still a workhorse for me in my revision total knees. So it's a difficult patient if they come to me with data that says they're allergic to cement.
They,
But I think on the hip side, you know, I think cobalt chrome heads, nobody's using them unless they're having sizing issues. So in the hip side, we've gotten really away from this because of the majority of people using ceramic heads on everybody. And, you know, even if you're trying to be cost effective, like I don't put a metal head on a 90-year-old just because they're 90. And I don't think trunnionisis is going to rear its ugly head. With what we know about cobalt chrome and trunnionisis, I put a ceramic head on everybody.
Yeah. Ed, you have some comments?
Yeah, the blood work we do when we do it does test for all those other sensitivities, cement, monomer, things that I have no idea what they are. But a patient will say, you know, my hip hurts, it's titanium, and we'll do the workup. And I just tell them I hope not because I can't make the next one out of wood. So I'm out, and cement is mandatory in revisions. We haven't come up with a great press fit revision solution with significant bone loss. So we had one revision person, a patient who came in aseptic loosening of a total knee, revised at aseptic loosening of total knee, despite zonal fixation with cones, and it turned out they did have no infection. They had a cement allergy. We didn't have a good solution. We ended up cementing them again, and you know, lo and behold, they're staying together. But I'm not saying that caused the loosening. It was just interesting. I had no other ideas. The bubble gum wasn't going to do it.
Interesting. Interesting. So let's talk about innovation for a second. I always like to say, and I've said this on other open mics, that I define a great innovation as one that if it came out first, no one would ever think of using what they've been using already. An example would be if I had a device here called a photographic film, and it would produce negatives, and you could take a picture and send it out, and a week later get back pictures of which half of them are horrible. Would you buy that from me, or would you stay with your iPhone? If the iPhone came out first. I even use that with some pharma products. Like there's a long-acting cortisone. If it's expensive, the long-acting cortisone. So, but I said, if that came out first, would anyone invent short-acting cortisone? Yeah, I have a great idea. I have a cortisone that works half as long. So let's talk about the advances that industry has responded to not only over the years, but what all of you guys may or may not be using now to help solve this problem. And I'll start with Adam, because I know you're very aware
Yeah.
of this.
No, I mean, I think I love the way this discussion is going because I think you guys framed it really well. The ceramic head that we use on every single hip now is very much analogous to our hypoallergenic femur that we're all trending towards. And I know Frank, uses Persona solution 100% of the time. I do. We've also gotten away from cement. So in terms of the innovation that we've, been thankfully the recipients of in the knee replacement world, a lot of what we used to kind of wring our hands about 10 or 15 years ago is kind of gone now, right? So
Yep.
all of my primaries, like Frank's, get, a Persona, titanium, surface treated titanium nitride femoral component. And I just don't worry about that anymore. And for the most part, they're going in cementless as well. So I'm not worrying about that either. So when we're talking about some of those innovations, like if you had them now, would you ever go backwards?
Yeah.
You know, uh, the answer is no, and it influenced me back then when I had these patients 10 or 15 years ago, and they come in and I'm convinced, the patient's convinced they've got a nickel allergy or some sort of allergy that is pushing me to use a knee implant that I really don't like. That's a stressful situation to be in
Yeah.
as a surgeon, and say, okay, this patient's going to force me to use something that I use maybe once a quarter. I hate doing it. And now we're not saddled with that same burden anymore, which is great.
Yeah.
Yeah, we've said some names, and
Yeah. I
now that I
know.
have something that it's not a coating, uh, it's harder. I'm pretty happy. Previously, I didn't have a good feeling, and oftentimes I had a partner that used one of the other products on the market, and I would send that partner those patients because he was already comfortable with that implant, and so for me, it was just better for the patient and for me because different rep. I didn't want to change a lot of variables in my OR, so
Sure, that's an
oftentimes
interesting point. Yeah.
I would send my I had a partner who used Smith and Nephew, and it was an easy jump for him. So early on in my practice, my first 2 years of practice, anybody that came to me with needing a revision for metal allergy, I sent them to my partner.
Yeah. And that's a good point. That's something I talked about earlier, the idea of if you're using a certain philosophy of how you put in your knee and the advance does not match another part of your philosophy, what do you
Mhm.
do? You know? Ed, what's your thoughts about this
I'll
idea?
tell you, you go and you help, you're part of a panel, and it's always amazing what you take away from it. You get very excited about the Zimmer Persona and all of its options, sizing options, the MC Poly. I've been using a lot of T Mini, and you share that with the patients. You get all excited, and you can't wait to do their knee. They're going to have a uncemented persona, and they're going to be back to normal. Oh, wait a minute, you got a nickel allergy, and how do you go back on that? This is before
Solution.
the solution. So now it doesn't matter. I have not made the transition, but it makes sense to make the transition to the persona solutions because it takes a variable out of the equation that could be. So when I do have a revision of mine, it has nothing to do with nickel allergy. The revision system also, Zimmer Persona revision solution, that's the revision system I want to use. I don't want to switch to any other brand, Smith and Nephew revision. I have trouble balancing that knee. My point is now it's a seamless from my primaries and my revisions, and I'm sure down the road they may go with the RHK if things continue to trend that way. But it
What's
makes a
the
lot.
RHK? What's the RHK?
Zimmer's
Uh,
hinge.
Oh, the
Rotating
Zimmer hinge.
hinge knee,
Zimmer hinge. Just let me
RHK.
clarify that for everybody. Yeah. So
so
vision hinge
uh,
knee. Yeah.
I may be calling the rep when I get done and say, let's pull some inventory.
Your rep's on the line. He's already pulling inventory. I could see him now.
Oh,
He's in Sarasota General. Yeah. So we're there. So now let me ask, how long have you been using Adam? How long have you been using the Persona solution?
I've been using it, I would say, as soon as it came out. So it's probably at least a year and a half, close to 2 years,
All
probably
right.
close to 2 years. I've got probably 400 or so in.
All right.
They do great. I mean, I think, everybody loves their particular knee. I think to Ed's point, having a portfolio that kind of covers all your bases is nice, and not having to kind of leapfrog around different things for different clinical needs. I just think it lends itself to, clinical efficiency and comfort for the surgeon. So I'm very thankful to have that in our armamentarium.
So I'm going to push you a little bit. You've done 400, which is more than enough to see some trends.
Yeah.
The community, what I call citizen surgeon, will do about 35 knees a year, and tough to see trends in that. Have you? Let's go back to metal sensitivity. Have you seen any trends as far as less painful knees, possibly, and less?
I would say
Hard because we
yes,
know the
although
benefit. Yeah.
I haven't pulled the data, but I would say yes. I mean, I think some of this gets caught up in alternate alignment philosophy as well, and putting in knees, like Ed said, I use a lot of T-mini, putting in knees, respecting their kinematics a little bit more with an alternative alignment philosophy, using less soft tissue releases. So I do think patients are getting better a little faster than they used to. Um, have I seen less metal hypersensitivity since I've converted over to this? I can't really say that I have, because it's such an infrequent thing in the first place. If the incidence is so low, I think that's part of what makes, if you look at the literature
Yeah.
and the data that's out there, interpreting this is difficult, because so many of these things are case series and case studies, and it's hard to make any concrete science out of that. But I can tell you that my patients are really happy. I can tell you that cementless designs, especially Persona's cementless, work great. Um, I haven't had any with fibrous ingrowth or any problems with that. And I certainly haven't seen any metal allergy issues, um, because we don't have those metals in our implant, which is wonderful. I'll put one more thing to you, which I think is interesting. And I think
Sure.
Peter Skolko at HSS kind of coined this term, the swimmer's knee. One of the things and we all have patients that say, oh, doc, my leg feels so thick, it feels heavy. How much did that thing weigh that you put in there? And one of the benefits of solution is that the femoral component is literally half the weight of the same cobalt chrome component. Now, is that something that the patient can actually feel and perceive and notice a difference about? Probably not. Um, but they all seem intrigued when you tell them that. So
Right.
yeah, the one I use now weighs only half as much as the one I used to use, and they get excited by that.
Well, they feel they're going to lose weight. That's why.
Yeah, that's a quick way, right?
Yeah. It's a quick way. Frank, some thoughts on this?
Sure. I mean, I agree. The number needed to treat to find a difference. We're looking at something, I think, the rarest reason for revision in my practice. But as a surgeon that's 12 years out, the one thing that I worry about my practice is a lot of variables have changed in the last 4 or 5 years for me. Press fit, alignment philosophies, robots. I've changed a lot of variables in my practice. So I think it's important for all of us that are doing so to really critically evaluate our patients, because so many things have changed in the last 5, 6 years.
Right. Yeah. And I think you mentioned you're using the T-Mini as well.
I'm not. I use Rosa.
You use the Rosa. Okay. And Adam, you use the T-Mini.
Yeah, I'm a T-mini user. Yep.
And Ed, you're using
I did a significant amount of rosas, and then I'm now 100% T-mini. And I'm not doing that many, that is going to change after tonight, of the solutions, but my press fit volume my percentages have gone up significantly. And I think having that mode of failure, particularly in a younger patient, go away with the cement interface is incredibly reassuring. And I'm still sitting here thinking about how much lighter it is. And I do have women ask me that all the time. That's just,
So now you have an idea. You have a solution.
yeah.
I
90
love it.
pounds, she wants to know what her implant weighs. That's interesting.
Yeah, I have my okay, head. Sorry, go.
I think long-term data is important, but short-term data for press fit is important because we're looking at ingrowth. And, now when I'm doing a knee and I cut somebody's tibia and it just looks like marble, and before I used to pop 14 holes on their medial side, I really enjoy putting a press fit in that, because I don't think you can get a great grout in somebody whose bone is like that. And I always worried about cementing those patients.
Like trying to cement into a steel tube, just doesn't stick. In that scenario, I'll ask you. I know we're in the middle of a conference here, but I might take an extra millimeter of tibia, even with press fit, to try and get rid of that eburnated bone. I'm still exploring my press fit. The other thing I got to be careful. I often run the saw blade through my 4-in-1 cutting guide a couple times just to make sure when I press fit that femur, I don't have it doesn't bind up on the way in. And I will tell you, with the Persona femur, I really haven't seen that happening at all. It's been seating nicely.
But Ed, you raise an excellent point. When you see that, marble medially, if it's not egregious, I'll, adhering to more kinematic principles, put more varus in, maybe take a little bit more, get below it, so that you have more permissive bone for biology. But I agree 100%. You can't cement onto that. If it's that Carrara marble medial slick surface, no cement is ever going to stick to that.
Yeah, it's true. Frank, you brought up another good point about changing philosophies, and both you, John, were talking about alternate alignment. Remember that saying to like thou shalt not varus and all if it's 3 degrees of varus, you're going to have higher failure rate. Now, I'll put 3 degrees of varus in the femur, 2 degrees in the femur, in the tibia, and not think twice about it, and also not have to cut any ligaments. So it's exactly what Frank's saying. So many things are changing for the better.
I was going to push a little bit because we talked about cement and these marble skin, no, sorry, marble bone. Um, let's talk about cementless TKA for a second, as it relates to maybe this implant, but in any. When it comes to cementless TKAs, where is your patient selection in that? Is it everyone's getting cementless, or you getting part half and half? 82-year-old. I'll start with Adam, looking at him on the right side of my screen. So
I was going to say, maybe you should finish with me because, in the participation in these sorts of things, I'm a little bit crazy, but I'll tell you what I
you're
think you
from
ought to do,
Texas, so it's okay.
from New York.
Yeah.
But yeah, the reality is I go cementless on 99% of people now. I very seldom use cement, even in 80-year-olds, and even in bone where, 5 years ago, I would have questioned my sanity. But that said, I think you always should start with the problematic patients, to Ed's point, those younger patients, heavier, more active patients where you know that the cement is going to fail eventually. Those are your best ones to start with. And as you gain confidence in the performance of your cementless implants, you expand your indications. But
Yeah.
they're very forgiving. And just a shout out, to asymmetric base plates. I think one of the keys to having tibial
Coverage.
components that don't subside, don't move, is if you can sit them on cortical bone well, as you can with the Persona tibial base plate profile, as opposed to symmetric base plate, you're just going to have less problems.
Ed, do you have any criteria such as age, obesity, activity level on cement or cementless?
I've taken age for the most part out of most of my equations and look at bone quality, first radiographically and then physically in the operating room. And I am not as far as long as Adam is. I don't want to exaggerate, 45, 50, 60% press fit. Maybe the last couple of months as much as 8, just because of patients, 80% because of patient selection, but it's certainly expanding. And I have not had to take anyone back, and I've been using press fit for some years for a fibrous union yet, or collapse or fracture. So I'm still working. So would I press fit in my hands a 70-year-old osteoporotic woman who had a femoral neck fracture that I fixed 3 months ago, and I'm doing her knee? Probably not. But would I press fit a 90-year-old with phenomenal bone? Yes.
Agree with you. Yeah, I'd do the same.
Right? Yeah, your indications are similar to Ed's, or are
Similar,
you?
I think. For me, though, I think it's important. I teach residents, they need to know how to cement a hip and they need to know how to cement a knee. So, all my femoral necks that I do a total for, I cement every single one. And I think there's data that says I don't have to do that, but I use it as a time to teach cementing technique. And then on the knees, the patient that I worry about is the osteoporotic valgus knee, especially older, because the varus load on the medial side of the knee, when people are taking a step on that more osteoporotic medial side in the valgus knee, that's the person I worry about press fitting. Other than that, I'm kind of press fitting everybody.
That's a great point.
That's a great point. Yeah, that's really good. So I'm going to flip back a little bit to metal sensitivity again. our secondary topic for a little while, now our primary topic once again. Um, the question is, at some point in time, we could ask, are we solving biology or are we solving patient concern? And I think we discussed that to some extent. But could a widespread persona solution or other type of hypoallergenic implant use become the standard of care, whether or not we have clear evidence of metal allergy or not? That's the
Yeah.
question.
There's one thing that happened that when the Europeans came out and put cobalt chrome on their danger list or cancer causing list, that was a wake up call for me to say, I need to learn more about this if people are that worried about it. It's interesting, European data versus our data. Some things I think we're better at, some things they're better at, but I really listened to that when they called cobalt and chrome a carcinogen in Europe.
Wow.
Yeah. Some of that, again, it's perfect situation, Frank. Some of that becomes a little sensationalized, right? Because elemental cobalt is what is the carcinogen. Cobalt, chromium, cobalt, and chromium ions being bound in a metal probably aren't viewed the same way by the EU as elemental cobalt. But to the patient, it doesn't matter. If the patient's perception is, hey, my surgeon wants to give me cancer, that would be a horrible perception, right? So I think, Ira, for me, to your question, I think this will be the standard of care
Okay.
5 or 10 years down the line because of a variety of issues, the cobalt issue being one. Obviously the most common thing in what we're discussing tonight is a hypoallergenic implant option with sensitivities to nickel, cobalt, and chromium being a concern. And then whether weight and fixation issues of the implant factor into that remains to be seen. But I do think that the future is moving towards, this being the gold standard, if you will, for femoral component selection in the future.
Yeah. Frank, you feeling about this?
I agree. I think it's already happened in my practice. I'm not saying everybody should follow me, but more people are doing it. And, I feel for the person that you talked about that has a philosophy that uses an implant that matches their philosophy and has good results. Are they going to chase such a small percentage of your painful total knee patients if their product line doesn't offer it? That's where I think it's going to be an issue. Because if somebody has great results, it's tough to change for such a small patient population that we're looking after with metal sensitivity.
Sure.
When there was limited options with vendors, that solution wasn't enough to drive people from what they considered a better implant to that hypoallergenic implant. But it's a totally different story now, right? We have the implant we want to use that's going to have the same track record. It's going to have the same biomechanics. Nothing changes about what I do with that knee, and it's lighter. But if you look at the progression just in anesthesia, we used to do general. People used to stay in the hospital 3 days. These were all things considered the norm. If you would have said outpatient total joint 20 years ago, very few people were doing it, and that in itself would have been, a concern for medical legal because it wasn't standard of care. So everything progresses. Why wouldn't implants progress as well? So I don't see the need to use a cobalt chromium femur any longer. And it's funny, I'm like the audience member being converted because
Convincing you.
it makes complete sense. What is the gravitation towards an archaic implant that I even have to think about sensitivity? Why do I have to think? Now I don't have to think about it. What if it was somewhere, if you use this, you would never have to worry about infection. It'd be holy crap. So I've had a Jesus moment.
Excellent.
I love it. We're converting people.
Adam, something came out of Texas. It's not coming out of Boston or out of New York.
It's
came out of
amazing.
Texas.
And not yeah. I mean, this is like a watershed moment for us.
Yeah.
I imagine a lot of the audience has very similar feelings. That would be a poll. Did this
Well,
conversation change anybody's thought process on access and utilization? I think it will.
it's so exciting. Is that when I look back at the beginning of my career, I used the IB2. Okay. Actually, I had experience with the IB1 for a short while, and then the IB2 came out, and it was unbelievable, but it didn't solve so many things. Isn't it so exciting now that we're talking about solving something that happens less than 1% of the time? And in a sense, we solve so many other things along the way that
Yeah.
it's kind of exciting for me to listen to all you guys. We're talking about getting that 1%, that 5%, and looking back, 20, 30 years ago, we had other problems. We had stability issues, mid-flexion instability issues, and
Four
fixation.
sides. We
Yeah,
had four sides.
yeah,
Yeah.
that's true. It didn't cover the cortices and stuff. So,
Yeah.
as I like to say, this is always the fastest hour
All right.
in America. We're nearing towards the end. So, what I would like to do, I'd like each of the faculty sum it up, and I'll do it in alphabetical order. I'll start with Frank by last name. I'll start with Frank. And to sum up a little bit of your general feeling and where things are going in the future, or and where do you think we're going to land in a few years?
We specifically talked about metal sensitivity in knees, and we didn't talk about it anywhere else today. We talked about hips a little bit, but I think we're all trying to make that percentage of unhappy total knee patients better. And this is part of that percentage of unhappy total knees. And a lot of things have changed in my practice in the last 5 years. And I think the goal of that is to get knees closer to hips. And I think that's all of our goals. And I think this is a smaller subset of that patient group. But for me, now that I have it in the implant that I like, it's been nice for me. And I think hopefully I'm doing a better job at narrowing the window or narrowing the gap between total knee results and total hip results.
All right. Adam, you're up.
Yeah, that's a great point that Frank made. I mean, I think we're all trying to get our knees a little bit more like hips. And certainly, I think not only implant innovations that we have with our hypoallergenic implants and cementless implants, but also alignment philosophy. So I think we are, I think, closing the gap and fixing some of those problems that make the total knee results disparate from the total hip results. And I think that's an exciting time because ultimately, we want all of our patients to do great. We want all of our patients to have durable outcomes that keep them happy forever. And as each kind of iteration of these things comes along, the companies are providing us with those tools. It's just a really exciting time to be in the total knee world because I really do feel like we're kind of chipping away at some of those last, 10, 15% of the problems that we can, whether it's through an understanding of an alignment or through better implants, get to a circumstance where we're making more patients happy. So it's a great time to do what we do.
Yep. Ed, you want to bring us home to
Yeah,
Florida?
I'll say it like this. Metal sensitivity is nothing new. If I felt that strongly about it, and perhaps it was greater than 1%, I would have used a product that didn't have that sensitivity, Smith and Nephew, whatever. But now that I've been, I have the ability to use the implant I want and love and continue to move forward with that implant. Now I don't have to worry about the metal allergies anymore. So I have the implants I want, the outcome, the balancing, and all the advantages in a hypoallergenic way. So what more could I ask for? I would say this. I think we got to do a topic sometime. We got Rosa, we got T-Mini. We should do a technology, and then we have Monogram coming down the pike. We really should. I'm not Ira. I'm not trying to
No,
direct
we
you.
want more. We want more. We want more.
It would be an incredible conversation with these guys how they're utilizing technology, and very similar. Anyway, it's just a little food for thought.
Yeah, no, it's great. We have room for that kind of stuff, and I think it's a great idea. Um, First of all, I want to thank all of you for spending your time and the 90 people who showed up tonight, a little more than 90, which was great. This was an eye-opening discussion for me. I think commend all of you. You guys have great practices, great surgeons, and a great contribution to the orthopedic community tonight. So I want to thank you very much as we say good night.